I'd like to start now. So I welcome you to the University of Waterloo. I'm Shirley Fenton, manager at the Infonet Project, and one of your hosts today. We're very pleased to see you all at this event, and I hope you'll be so pleased with this event that you'll ask your colleagues to come with you to the next one and to the ones that go on into the next year. This is the second of a series of seminars on smarter health, the Innovators, and the series recognizes the innovative contributions of public and private partners in collaborating to innovative solutions in the healthcare enterprise. This seminar series is a joint effort between the Infonet Project and the Education Program for Health Informatics Professionals, both at the University of Waterloo. We started the Smart Community Seminar Series several years ago to explore the impact of information technology on the community, and we have evolved to focus on a particular part, and that is health. So this is the second year that we are exploring the impact of information technology in the health industry. Today our speakers are Andrew Szende from the Hospital for Sick Children and Pat Billard from IBM. They'll be speaking on integrating the health record. Now, I don't know about you, and I guess that's why you're here today. I'm really interested in this topic, and it should be quite an exciting one, so I'm looking forward to our speakers telling us more about this topic. Before we begin with the presentation, I just want to make sure that you know that our next seminar is on November the 20th. It will be here, same time, same place, at 3 p.m., and our guest speakers will be from Medicalis Corporation, and their seminar topic is Reducing Medical Errors, Applying Just-in-Time Knowledge. So I think that will prove to be a very interesting seminar as well. So let me introduce to you Dominic Covey, Director of the Education Program for Health Informatics Professionals, also co-host of the seminar series, and Dominic will introduce our speakers.
Thank you, Shirley. I first heard about Andrew almost been at least 2 years ago when one of the people who works with us, Jan McNeil, came back and was raving about what he had done in Toronto. I think you'll see what's been accomplished here is something that needs to be accomplished, and it's been done particularly finely. Andrew is a Chief Executive Officer of eCHN, the Electronic Child Health Network. He's also an Assistant Professor of Health Policy Evaluation and Management in the Faculty of Medicine at the University of Toronto. His management and communications background in both the private and public sectors is an unusual mix of the private and public side of the health system and the general industry. In the past, he was a management consultant, which we won't hold against him. I'm sure he did some good as well as evil. And he facilitated the creation of the Rouge Valley Health System. Earlier, he served as Assistant Deputy Minister of Health, Associate Secretary of the Cabinet, and Ontario's Chief Economic and Trade Representative in Hong Kong. I'm particularly honored that he was willing to come here to the University of Waterloo. I asked him if he was going to wear his crown in this earlier today, but he didn't wear his. Patrick Billard is a solution architect and health network solutions of IBM Global Healthcare Solutions. Pat was involved in the building and deployment of eCHN from the beginning, more than 4 years ago. He's been with IBM for more than 25 years, which I commented he should have been replaced by a new version at least 5 lifetimes ago. I welcome both of you. I'm looking forward to your presentation. I understand that Andrew is going to give the main presentation, and Patrick will be taking questions and livening us up at the end. Thank you.
Thanks very much, Shirley and Dominic. It's a pleasure to be here. Actually, I do have a little bit of history with the University of Waterloo, and I'm just very pleased to have been invited here. Some years ago, when I was working in Hong Kong, I actually had some students come over from the University of Waterloo to be co-op students in my office in Hong Kong. I guess it was a fairly nice assignment for them, and I found them to be terrific workers. So my first impression of your university was a very favorable one, and certainly today, coming here and walking around, I was very impressed again. I do appreciate the invitation, and I hope that I'll be able to live up to your expectations. Feel free to ask any questions. I have deliberately left out some crucial parts of this presentation to give you an opportunity to explore in greater depth some of the things that need to be explored. So I do encourage you to ask lots of questions. I will try to leave enough time at the end for us to have a discussion. Just for those of you who are not that familiar with the healthcare system, it's important to remember who provides healthcare in our society. And there are all sorts of people. You know, your first impression is that, well, doctors provide healthcare. Well, yes, doctors do. But there are lots of other people, nurses, therapists, all sorts of other people. And so that's one important element of the background. The second one is, where do they provide this health care? And again, the most obvious place we think about is the hospital or the doctor's office. But again, there are other places where health care is provided. It could be at home, it could be in nursing homes, in homes for the aged, chronic and rehab facilities, and elsewhere. Now, the next question is, who keeps health records? Well, by law, they all have to keep health records. And so all those providers have their own health records. Typically, in the past, they have been in scribbled, handwritten form. Increasingly, they are starting to be in digitized electronic form. And that's an important part to remember as well. And finally, the fourth part of this background is, where are these health records kept? Well, obviously they're kept wherever the health care is provided. So they're all over the place. And that's what poses the challenge for integrated, shared electronic health records. How do you bridge that gap? How do you bring those records together from all those providers in all those different places into a single view? There are other challenges. Even within a single hospital or organization, you have a number of different health information systems which are sold by different vendors, and you can call up the information that particular system was set up to provide, such as a laboratory system or a radiology system or an admission, discharge, transfer summary system. So the issue becomes, how do you get to see what is contained in all those different systems, even if they are in the same organization, all on one screen? This problem is magnified when you have a number of different venues where the health care is provided and where the information resides. You need to pull it together. And of course, you want to do it electronically because you would just never succeed in trying to pull all those little pieces of paper together from 2, 3, 4, 5 different locations. There are health records. Of course, everybody is required to keep health records, but there are problems with them. And here are some of them. As I already mentioned, some of the records are here, some of them are there. Nobody has a complete record. Even if you are within a single site, it's possible that somebody has signed out that record, somebody else is looking at it, and it's not available to you. So what do you do then? If hospitals will not admit to this, but let's say the record is misplaced. Somebody took it out, left it on top of the filing cabinet, and the next person needs it. Well, you can't find it. You can't get it. What do you do then? Sometimes what happens is, particularly with radiology reports, different versions of a report are issued. The radiologist will dictate a particular summary report immediately after looking at the images, and then we replace that with a more elaborate, a final report, or at least a next version of the report 4 hours later, or a day later, or 2 days later. Well, then you have two different versions. How do you know which is the correct one, and which one are you actually looking at? Finally, community physicians who are not in the hospital but who are looking after the same patients. Remember, the patient, this is a very patient-centered exercise. Community physicians don't have access to those bits and pieces of the record that you can find in these various institutional locations. So those are some of the limitations of what happens. Let me try to give you a sort of a very simple but concrete example of a cancer patient, and I deliberately used Grand River as the example. A patient who is looked after, and this is quite common with cancer patients, both at Grand River and at the Hospital for Sick Children. Typically, there are test results that are taken that are available to the healthcare providers, either in Kitchener or in Toronto, but rarely in both places, because the data resides wherever the test was done. So why can't we have a single record that includes all the data from both Kitchener and Toronto in the same view, so that the decisions that are being made by the healthcare providers are the best possible decisions for that 7-year-old cancer patient? If that patient happened to be in Orillia, which is no farther from Toronto, from sick kids, than Kitchener-Waterloo is, the charts would be available to the doctors and nurses and therapists both in Orillia and in Toronto. After every test or every treatment episode, the healthcare providers can view a consolidated, integrated version of that patient's chart and can make the best possible decision about what needs to happen next, respond to any new crises that may emerge, and just as important, keep the parents informed about what's going on with their child, so that they're not in the dark about what has just happened during the latest visit to Toronto or during the latest visit to Orillia. And this brings us to what we are all about. eCHN is the way it's pronounced, the Electronic Child Health Network. What it is the start of a comprehensive, lifelong electronic information sharing system. It's designed in such a way that even though we are only dealing with children at the moment, in the future it can be expanded to include the entire population or any other subset of the population. It was originally done as a proof of concept project, and it has now emerged into a not-for-profit enterprise centered at the Hospital for Sick Children and involving about 8 other institutions, mostly in the Greater Toronto area, except for Orillia, which is a little farther away. And it has evolved from an IBM technology, which we continue to use and are very proud of because it's the backbone of what we do, to a partnership with about 20 other companies that have helped us along the way and that are involved in providing this service to the kids whom we are here to serve. The name we have given our service is HINET, or Health Information Network, and it is basically a secure electronic centralized database of Ontario children's health records that is accessible only to authorized healthcare professionals. The philosophy that we follow is a very simple one, and it's one that I would think most people would agree with. Has 2 parts to it, and that is that any information that you need to make decisions about your health care should be available to you and your health care provider, and that information should be available wherever you may be, whether that is in a hospital, in an office, in a clinic, in a long-term care facility, at home, wherever you may be. This is a depiction of what the network looks like. These are some of the organizations that are currently involved in eCHN. If you can just imagine that each of those icons represents a hospital or healthcare organization. Within each organization, you will find a number of what we call legacy systems, health information systems that are sold by these different vendors, which normally can't talk to each other within the same organization, let alone across organizations. So let's say at Sick Kids, we may be dealing with 4 or 5 different systems for different purposes, one for laboratories, one for radiology, one for admission, one for transcription, and so on. And then you sort of you add to that, 4 others at St. Joe's, and 4 others at Aurelia and Credit Valley, Bloorview. You get the picture. There are all those different systems, our task is to make sure that all that data that is contained in all those different systems is pulled together into a single view, so that when a child presents at any one of these facilities and you call up that child's record, it will contain the data from that hospital and from the previous hospitals where that child has been previously seen. We also have a number of community physicians' offices involved, and they too can log on and check on the progress of their patients. For those of you who are interested in the different vendor systems, these are the actual systems that we are currently connected with, whose data we collect into a single view. And as you can see, they represent many or most of the major vendors of health information systems in Ontario today. ADT, by the way, stands for Admission, Discharge, and Transfer. Transcription is anything that is dictated and then transcribed, whether they be clinic notes or notes by a surgeon after an operation, or the discharge summary by the attending physician. The radiology reports are obviously reports by physicians based on the scans and MRIs and so on, radiology images, and laboratory reports. So once again, the data from all those systems comes into the single view that then becomes the integrated, shared electronic health record of those kids. One of the important things that we wanted to accomplish in this solution was to make sure that we did not try to force people to replace what they already had. Remember, they own all kinds of information systems which are pretty expensive, and there would be a great reluctance on the part of hospital administrators and others to throw out what they have and buy a new one simply for the sake of having a shared record. Not that the shared record doesn't have value by itself, but it would be an enormous impediment if you had to do that. What you can do instead is simply buy the best of breed, whatever you want. Whatever you had in the past you can keep, or if you want to replace it with whatever is the most up-to-date new system that somebody else is selling, you can buy it, and we can connect and draw the data from it into our integrated shared record. So you don't have to make any changes to your system. And very important from the point of view of hospital administrators and others who value their sovereignty, their independence, it leaves control and custody of the records in their hands, so that we don't take over responsibility for their records. We don't mess around with their records. Their records remain intact, and we simply take a copy of their records and share that copy in an integrated fashion with the other doctors, nurses, and therapists in our network. Confidentiality. This is an area that you might want to ask some more questions about subsequently, but let me just touch on it very briefly here. We assume that our current paper-based system, or our past paper-based system, as it's becoming less and less paper-based, was a secure one and a confidential one that we could trust. Well, yes, the system does rely on physical security. It can typically be accessed only by professionals because the records are kept in filing cabinets somewhere in the health records department, usually in the basement of the building. And yet, sometimes the charts are taken out and left in open spaces at the nursing station or on top of the bank machine or wherever. Nevertheless, we consider it to be a good system. Why? Because the charts are difficult to find, and if you do find them, they're hard to read. So that's part of the mystique of the security and confidentiality of the current system. Now, what about the electronic chart security? Well, we have tried to match the paper security as far as it goes, in that the eCHN system can only be accessed from a secure area of the hospital or the doctor's office. You have to log in with your name and password to access the records. And we have added 4 other levels of security, or 4 other security policies. The first one is that the data travels through a private network. It does not travel through the internet, although it would be possible and will be possible in the future for it to travel through a virtual private network, which will be just as secure as our current private one. But right now, all the data travels from institution to institution or from institution to doctor's office through private lines that we are renting from AT&T and Bell, so that there is no question of any contamination or any exposure to anything else. Secondly, we have it set up in such a way that the chart is locked away after a certain period of time if you're not using it, so somebody can't sort of sneak in behind you and try to use the system and call up a patient's chart in an unauthorized way. Although if they do, as I'll show you in a second, we can catch them. Next and most important, and again this is an area that you might want to explore with us later, is consent. The system contains only consented data. Every time a new patient enters one of our institutions, we ask the patient, if he or she is over 16, or the parents, if the patient is under 16, to sign a consent form allowing us to share their health data with the rest of the network, the other healthcare providers in our network. And if they don't wish to do so, then we don't share it. It simply doesn't go into our database. And finally, as I'll show you in a second, there's an audit trail that is kept of who has viewed the charts and when. And this is what it looks like. When you actually log on, you find that one of the first screens has a button on it which says Audit Log. The rest of it is your typical basic information screen that you can look at for name and address and so on. But the audit log is important because if you as a healthcare provider or the parent has any concern about who has seen that patient's chart, all you need to do is click on that button, and up comes the most recent audit log that shows you exactly who has seen that patient's record and when. And if you see a name on there that you're not familiar with and you're sort of wondering well, who is that person and why did he or she look at my child's record? Well, then we can go and investigate and find out why did that person look at that chart, and was he or she authorized to do so. If you do call up the record after you've gone through the search to find the particular patient, this is what it looks like. It's, as you can see, it's designed to look as much like a paper chart as possible, with a table of contents down the left-hand side. A table of contents down the right-hand side, the basic patient summary information, the core data about the patient on the left-hand side, and then in between you have the actual item that you called up, the actual report that you called up. An important element of what we do is called the MED, the Medical Entities Dictionary, which is a way to normalize the data that is entered into these various systems. One thing I should explain, in case you don't know, every laboratory system, for example, that is manufactured and installed at any particular hospital will have certain peculiarities. They will call certain tests one thing, and that a different system manufactured by a different vendor will call that same test something else. The expected normal, in quotation marks, ranges will also vary between system A and system B. So we have this Medical Entities Dictionary that, first of all, standardizes the names of the tests and the expected ranges for normal results in each of those tests. So when we integrate the data from all those different systems, we can present it to the user in one of two ways. In this integrated enterprise-wide way, or if you're more comfortable with the data that you used to get before you had the integrated way, you can click on it and go back to seeing it that way as well. So you have a choice. We, of course, are encouraging people to use the integrated way, because ultimately that's the way that the data is going to be made available to everybody, and that is going to become the norm. But the transition may take 10 years or more. And in the meantime, we provide an opportunity for people to click on the results and get a previous version, as it were. That is the original version of the data that they're familiar with. Here's an example of the lab results. When you order lab tests, and I'm sure that you've all had this experience, you're sent to the lab. They take samples and then send the results to either your doctor if it's done in a private lab, or to it goes into the hospital system if it's done within the hospital. What our system does is it integrates the results from all these different systems and marks for you anything that is outside of the expected range. So there's an immediate flag, the yellow markings, for the physician to know that something is lower than expected, a result is lower than expected, or higher than expected. It also shows where the original test was done. In the case of this example, the first 4 of these tests were done at the Hospital for Sick Children, and the 5th one was done at Centenary Health Center. If you click on it, it will explain why that particular result is higher than expected. It should have been within the 150 to 400 range. It ended up being 405. And it gives a lot of other pertinent data about the particular patient, so that once again the physicians know exactly how to interpret this particular result. When it comes to radiology reports, it works the same way. The table of contents is on the right-hand side. You can click on one of the items that is available, and up comes the report in the middle. If you click on that little turquoise eye, which stands for image, that brings up the image that goes with the report. So first you read the report that was done by the radiologist, and then you click on that eye, and up come the images that go with that particular report. Here's how far we've got so far. We've got somewhere over 110,000 children's records in the system at the moment. It's just I put up these numbers for illustrative purposes. 110,000 children, 450,000 encounters. That means that many visits or encounters were involved in compiling those records. And technically what that required was more than 3.1 million HL7, that stands for Health Level 7, transactions across the network. So all these little bits and pieces of information, you had to send 3.1 million messages across to create that health record of the 110,000 children. Okay, so what are some of the benefits? I think that you will probably see those for yourselves. It makes it possible for people to access the data from any one of many different locations. It's readily available as soon as any new data becomes available, so that if a new test is done, let's say in Kitchener, but the child is being transferred to Sick Kids, well, the doctors at Sick Kids will have the results a minute or two after the doctors at Kitchener did. It also means a reduction in the number of unnecessary repeat tests for kids. Now, anytime you can reduce the number of needle pricks for a child, you're doing him or her a favor. Typically, children are not keen on needle pricks, and yet that's one of the necessary evils for drawing blood. If the results are available, then you only repeat what absolutely has to be repeated, as opposed to repeating everything in a routine kind of way because you don't have access to the previous results. The storage of this data becomes much easier. While, as I mentioned, it's possible that physical records could be lost, electronic records are there in a permanent way. There are backup systems so that even if the system were to crash, which it hasn't done, there would be a backup that you could go to and recover all the information. There's less physical storage space required. You no longer need these giant filing cabinets and rooms and warehouses full of paper records, because it's all captured digitally, electronically, in a very small space. You don't need a huge health records department, because again, most of the work is being done automatically, electronically, and a lot of the routine work is made unnecessary. You know, the sort of the sending messengers up and down the stairs, the searching for records, it becomes quite routine and can be done in a matter of seconds, as opposed to hours or sometimes days. So it's much easier to get to the data. It's also much easier to control who gets access to the data. Whereas with the paper records, it's entirely possible for for people to sort of sneak records out of a filing cabinet. You can't really sneak a record out of a computer system because every single move is logged by the audit log. Where is this all going? Well, we think that by the year 2020, all of Ontario's hospitals will have what we have today, an integrated shared health record, not only for children, as we are basically working with children, but for children and adults. We'll probably get there through a series of steps. It's unlikely that we will do that by just going from children's records to all adult records. More likely, we're probably going to have specialized records for cardiac patients, for cancer patients, for chronic and rehab patients, maybe for geriatric patients, emergency people who are more likely to present at emergency rooms, and eventually we'll have the whole province. And my guess is that it'll probably take us another 18 years to do that. But the good thing about it is that as we proceed in that direction, the decisions that will be made about your health care will be based on data, information, and knowledge that is shared among all the providers of health care, regardless of where they may be and regardless of where you may be. And that, in a nutshell, is what the Electronic Child Health Network is about. Pat and I would be very happy to fill in all the gaps that I've left in the presentation and discuss with you how this is actually functioning, and ask you to challenge us with your questions, and we'll try to respond. Thank you. Which one?
We have a bit of difficulty today and we don't have enough microphones. So what we'll do is ask our speakers to repeat the questions and remind each other to do that.